All right, so the next thing we're going to talk about is the passage. We have actually two parts to the passage. We have the pelvis. So the fetus has bones, pelvis has bones. So we've got to be able to fit the bones of one through the bones of the other. But we also have soft tissues. Okay, that's the uterus. I love this little model, it's so fun. Okay, so the pelvis has 4 bones and 4 joints. The symphysis pubis is the anterior joint. The pelvic joints actually loosen because of a hormone called relaxin. And relaxin loosens those joints to allow the pelvis to actually flex a little bit. Okay, so it can actually flex and change position or change shape slightly based on the position. That's important when we're trying to get a fetus that also has bones through this bony pelvis. There are 3 diameters. When we talk about pelvic diameter, there are 3 diameters. The pelvic inlet, not these big wings here, the inlet, okay, the pelvic cavity, and the pelvic outlet. The fetus has to pass under this pubic arch, which, if that angle is really narrow, it can make birth more difficult. Okay. There are 4 basic pelvic shapes. Most women have a gynecoid pelvis. There's a round pelvic inlet. The pelvic cavity is very short, not a lot of distance to go through. And the ischial spines, remember the little sticky outy bits down here at the outlet, those are pretty short. Okay. An android pelvis has a narrower anterior. This angle here is narrower, so it's more heart-shaped. Okay, that means it's going to be harder to fit through. The ischial spines are more prominent, they stick out more, and then the transverse diameter here at the outlet is narrower. Now, some women have an android pelvis. They may still be able to give birth vaginally, but they may have a little bit harder time getting the fit. You might have to have just a perfect fit, not too big a baby to fit through that pelvis. Okay. Anthropoid, the inlet, remember the top part where the baby goes in first, is more oval shaped. So it's less round and more oval. The diameter is larger from front to back, anterior, posterior, but the diameter is smaller from side to side transverse. So that can cause some difficulty getting a baby out. Platyploid is flatter, okay? So there's a narrower diameter front to back, anterior, posterior, and the pelvic inlet is kind of kidney shaped with a shallow pelvic cavity. That's going to actually probably be the most challenging. Now, women with a platyploid pelvis can still deliver vaginally sometimes, but they may have more difficulty. And if the baby is larger or not in just the right position, that may not be as possible. So pelvic shape is not it's not the only determining factor, but it is a factor in whether that fetus is going to fit or not. Okay, so we talked about the pelvis. Now let's talk about the soft tissues. We have our knitted uterus. This cuff at the bottom represents the cervix. I'm going to put the baby in the uterus because we're going to talk about what happens in labor. Okay. So we've got several soft tissues between the fetus and the outside. We have the fetus in the uterus. He's all stretched out, starfishing. Okay. With contractions, this cervix that is closed gets pulled up into the body of the uterus and gradually pulled thinner and pulled open. Okay, so the cervix is a continuation of the lower segment of the uterus. Okay, in pregnancy, it's closed, should be long. Okay, you can see in this model without baby, you can see the cervix is closed and it has this length right here. Okay. It probably is closed with a mucus plug until close to labor. If the mucus plug is lost and labor doesn't happen, you can actually reform that mucus plug. Contractions are going to pull the cervix up into the uterus. So the cervix gets pulled away as the fetal head gets pushed down. So there's mechanical pressure from inside. Let's go back here. Mechanical pressure pushing the fetus down and at the same time pulling the cervix up and open. So as it starts out around this long, and then as the contractions pull it up, it starts to thin. It gets thinner and thinner and thinner. And a lot of times it thins a good bit before it starts to open, especially if it's a first baby, first labor. So thinning is called effacement. In labor, we talk about dilation, effacement, and station. Okay. Thinning is called effacement, and it's estimated in percentages. So when it's probably about halfway as thick as it used to be, then we would call it 50%. When we get to completely effaced, we would say 100% effaced or completely effaced. Okay. You can have that cervix be completely effaced and not open very much at all yet. Sometimes in labor, as people are very focused on, oh, they've been 2 centimeters forever, but is that 2 centimeters with no effacement, or is that 2 centimeters with changing effacement? Because effacement, thinning, is still cervical change. As it starts to get pulled open, okay, gets pulled open, fetus gets pushed down against it. As that happens, we call that dilation. All right. Dilation refers to cervical dilation. This closed opening opens up enough to let the baby out. When we talk about dilation, we're not talking about vaginal dilation. The cervix has to dilate enough for the baby to come through it before the baby ever gets to the vagina. Okay, so when we estimate dilation by palpation, we use 2 fingers to check. We estimate dilation in centimeters. When we can't feel any cervix around the baby's head, then we would consider that fully dilated, which is approximately 10 centimeters. The pelvic floor muscles form, it's like a figure 8 with an extra loop, and they actually support all of those pelvic organs. The pelvic floor muscles help encourage, they provide just some stability, and they help encourage the fetus to turn in, to rotate in second stage labor. Okay. Now, when the cervix is completely dilated, then the baby moves into the vagina. The vagina actually lays in folds. The inner part of the vagina lays in folds called rugae. So when the vaginal canal, when those folds unfold, that's typically painless. Most of the pain in labor, you're going to feel cervical dilation. That's going to cause pain. Sometimes pressure against one of the bones of the pelvis. Going through the vaginal canal, the vagina itself, unless you have an odd presentation or something that causes injury, those rugae unfold. Now, at the introitus, when we get just to the introitus, the exit to the vagina or the entrance to the vagina, the vaginal outlet is tighter. And again, a lot of people will feel burning pain at that point. When the fetal head is distending and stretching the perineum, they'll feel some burning. That tissue, that perineal tissue between the vagina and the anus stretches and thins. Sometimes it will tear as the fetus is delivered, but allowing slower delivery can decrease the risk of those tears. We don't want the baby to pop out, because not only are we going to have tears we're going to have tears in the perineum and possibly other areas of the vulva. We have a lot of pressure on the baby's head. The bones are overlapping some as it's delivering. Pops out really quickly. Those bones can spring back too quickly and tear some blood vessels. So we don't want the head to pop out. All right. And the tighter perineum and the tighter vaginal outlet actually slows down that delivery. Once the presenting part has passed under the pubic arch, and you kind of, it'll go under and kind of duck duct underneath. Once it's under the pubic arch, then it's usually visible, or it's going to be visible at the introitus, even between contractions. We call that crowning. When we can see hair, it's not crowning. When we can see the head and it stays there when there's not a contraction, they're crowning. That means the head is under the pubic arch. Okay. Next section, we're going to talk about powers.